I have a lot of conservatism in me when I approach surgery. Like, I want to do the best operation all the time. I never want to be the person who misses a cancer. I never want to be a person who exposes someone to more risk. So, over 5,000 breast procedures, well over 500 explants at this point. I know those risks. I feel very confident I can take these out each and every time. And whether we take it out and say it's a total capsulectomy, a precise total capsulectomy, an en bloc capsulectomy, I think the goals are still the same, to take everything out as intact and undisturbed as possible for me so that I don't compromise a patient's care. I check the boxes for patients. I don't check the boxes for other doctors or entities or industry. And to me, clarifying their pathology at the end of the case requires all that material, to the best of my ability, be intact. So I remove it all as best of my ability intact all the time to give to the pathologist so they can make a diagnosis with or without staining, with or without additional information to help the patients. So there's no long-term health consequences from this. It's pretty important to identify these, especially in my patient who has one of the rarest lymphomas ever found in the world. There's only 8 of them when I submitted her case to MD Anderson. And, for all intents and purposes, she's cured because of the way the procedure was done. Now, she didn't have anaplastic large cell lymphoma. She had a different lymphoma. She didn't have a seroma. But had I just cracked this open and took it out piecemeal, I would have compromised her care and exposed her to unnecessary risk by doing it that way.